There are so many of us committed to improving the lives of the youth in our communities. The In It for Youth podcast is a place for us to come together, from professionals who work with and serve youth to those that champion issues affecting children, to community advocates and stakeholders, and insightful young minds too. The In It for Youth podcast is a tapestry of voices united by a dedication to youth well-being and empowering the young generations of today and tomorrow. I'm your host, Jamie Gale, and I'm so glad you've joined me on this team that is in it for youth. Hello and welcome back to the show. Thank you all so much for listening. It has been so awesome to hear how these stories are making an impact. I am loving sharing them and being a part of these conversations with so many amazing people working to improve youth well-being. If any of the episodes have impacted you or opened your eyes or mind to a new field or a new experience or a new perspective, I would be really appreciative if you would leave a 5-star review for the show on your podcast app. While you're there, do go ahead and hit subscribe. Those are the best ways that you can support the podcast so I can keep sharing these stories. I'm really excited for you to hear from my guest today. My guest today is Dr. Nathan Rosenberg. Nathan Rosenberg is a pediatric physical medicine and rehabilitation physician at Nationwide Children's Hospital in Columbus, Ohio. He is also an associate professor of physical medicine and rehabilitation at Ohio State University. Nathan provides medical care for children with cerebral palsy, brain injury, spinal cord injury, and other conditions that impact how they function. He is also a father, a husband, a vegetable gardener, and an aging trail runner and ultimate Frisbee player. Nathan and I grew up in the same neighborhood a million years ago, and since launching into our post-college adult lives, we've both been working away in our respective youth-related fields, so it is really exciting to reconnect with him today. Congratulations on all of your impact on youth well-being, Nathan, and welcome to the podcast.
Thanks for having me. Good to be here.
Well, okay, let's start with some definitions. We all know what a pediatrician is, but I would love if you could break down what is involved in the specialty of physical medicine and rehabilitation overall, and what that looks like in a pediatric setting.
Yeah, it's a good question. And it's funny because I was in medical school and I didn't know what that was either. It's not in front of you and it's really one of us when you need one of us. The big picture here is that we're function doctors. So we don't cure disease as much as we look at how someone lives on a day-to-day basis. And we look at their goals, ideally, and say, okay, what can we use in our toolboxes to help you get to your goals, as opposed to us making goals for other people. So that could be related to walking or hand use or communication or how you think, how you do in school, or in the case of today, your Paralympic bocce performance.
Awesome. So what are some of the ways that a physician in your field works with your patients? Is it by coordinating other services like OT, or like what is involved in that from a medical standpoint?
And that's part of it. Yeah, I think it starts with the goal and then you go, and we have, my metaphor is we have this box of tools and we'll pull the tools out if we need them. So the big start is, so there's 2 ways to get to one of us. And one of them is that you're born with a condition that impacts how you function. In which case we meet more on the slow version where you have a clinic visit and say, okay, here's where we are, go somewhere. And then the other version is that you have an injury, spinal cord injury, traumatic brain injury, and I'm going to point right over there because I'm at work. So you end up in that side of the hospital, and then we meet you on day one and provide a roadmap for the intensity of what is that first month of a new injury and a change in identity and a change in character. And that ends up being some hands-on things and a lot more communication about process. And then we end up being oftentimes the center of communication for OT, for PT, for speech, for therapeutic recreation, for music therapy, for massage therapy, for other physicians and physician groups, and for sometimes those really hard conversations about how things look and what goals are.
And setting expectations, I guess, of what could be and what might be and all of that.
Yeah, with some caution that the doctors aren't humble. So some of the research work I do is in prediction of the future, actually, and how doctors will, I think I'm being critical of us as a field, but I think it's true that we go in and we're like, this is what I think is going to happen in the future. And then everybody comes back to us with the same, the doctor said I wouldn't do this. The doctor said I wouldn't do that. And I'm like, wait, I'm the doctor. Maybe I shouldn't be saying this stuff, right? And what we have, not only in medicine, but in a lot of places, is it's been shown that humans struggle to predict the future. And so enter with humility and compassion. And I often just use the phrase right away, I don't predict the future. I'll tell you that right now. And I don't believe that I do. And I can guess at some directions things might go, and I reserve the right to be wrong because we're wrong all the time. And if you want to guess, if you're interested in hearing that, if you want me to guess, I'm happy to do that. But I want you to know that that's imperfect. And I think that's where trust comes in, especially in really intense situations, is can you build trust with parents and with kids too, because they want to know the future, and build it with humility first.
So do you tend to work with your patients sort of over the arc of their, I mean, I know it varies, but do you sort of oversee a patient's treatment over time, or are you sort of more of like an acute mission type of situation?
It's for a long time. Yeah, these conditions tend to not go all the way away. Every once in a while they do, but most of them they don't. And I'm pointing to things you guys can't see, but right over there, I'm sitting in my office, there's a pile of high school graduation cards. So there's your overtime, right? And so that might have been a kid that I met because I've been here for 11 years. Might have been a kid I met at age 7. And it's one of those, here's a graduation party from what was a 7-year-old at the beginning. And so, yeah, it is longitudinal. And I just came out of clinic, and there's a deep familiarity with each person that I saw. It's not always that way. Some things get better, and we maybe distance for good reason. But it's in general longitudinal.
So if you think about your clinical work, and obviously respecting everybody's privacy, but like what does a typical week look like for you in your practice?
Good question. So you can, as if we're not specialized enough, you can specialize more. And so I do some work with brain tumors, and that'll be a half day of my week with kids with brain tumors, and focusing on function and joy and community participation, or medical intervention, because sometimes we have to. I use Botox, right, for tight limbs. Yeah, there is still that physician aspect of things. Like some of our tools are really medical. And yeah, so Botox is great in our world and does really cool things and helps people live really well. But so some of that, and so it's like half of my time or so spent in clinic, half the time spent in the hospital. The part that I've chosen that I find to be the most redeeming for me is meeting people soon after an injury. And so it's called a consult service. And so kids in the hospital, either intensive care unit or on the floor, and being involved during that process, that early part has been really redeeming. And so that's a phase. So people do different things. We're a group of 8 docs, so people do different things. But that's about half of my time too. So I have 50% outpatient and 50% consults, and I'm like, wait, but I also teach
Right.
mentor,
Yeah.
and so it's probably not 50-50 because the balance is there. But the medical education too is another portion of it. So ideally trying to impart some things and be a humble mentor.
Awesome. So what does the path to get here look like? Is it like a pediatric residency and then a fellowship, or the opposite way? It's a PM&R residency and then a peds fellowship?
You got it. So yeah, so we went to college together. That was the first step. We were there, same place, same time. And then 4 years of medical school, and then PM&R residency is the most common, but not the only way to do it. There are some combined programs so you can do like a peds PM&R combined thing. And so it's like 5 or 6 years after medical school of joy and happiness. It was really great.
Yeah. Okay.
Especially at the end, like so I did a adult residency and then a 2-year fellowship. That 2-year fellowship was the best ever. Like you just you get to practice medicine, get massively underpaid, practice medicine, and not deal with any of the stuff, like the things that kind of pull you down a little bit more. It just didn't exist. Yeah, for 2 years.
Well, that's a really great attitude about medical fellowship. So you told me before we recorded that you don't think that physical medicine and rehabilitation is all that great of a name for the field. And I really got a kick out of that. And so why did you say that? And what do you think it should be called?
No, that's a good question. I don't know. I mean, the name doesn't really describe much. I mean, the rehabilitation part certainly is there, but it's a mouthful, and if you abbreviate it, has an ampersand in it, which like I don't want that. And so there's this word physiatry, which also explains nothing at all. So we have that, and I'm a function doctor, I'm a quality of life doctor. So I don't have a better name. I don't think any of us do. We
Okay.
can't even pronounce physiatry properly in
Okay.
different places of the country. So it's physiatry where I trained in Seattle, and it's physiatry here in Ohio.
Oh, interesting. That's
Yeah,
funny.
so I think I'm going to fail you with nomenclature.
Okay. 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 Well, you told me that you make sure that kids are able to get out and do things and you're a catalyst
Mm-hmm.
for that. And I really liked that
Mm-hmm.
explanation. I thought that was really great. So you briefly mentioned that you're also teaching at Ohio State, and that is really awesome. So what does that part of your work look like? Are you teaching med students or undergraduates? And like how does it fit into your other 50%?
Who knows? Who knows, right? I think so. We have residents that are always with us. We've got a pair that are always with our physician group, and so that probably occupies the most direct time for teaching. And they don't all go into pediatric PM&R. They all go into PM&R, but not pediatric. And so that still means we have a ton to teach. There's a ton to learn. And if now you're going to put me on a soapbox. So the education soapbox here, right? And so
Go for it.
just starting there, the education soapbox is this: lecture is dead, right? Like as an education mode, this is what people tell me, and I believe them. Lecture is dead, and customized education is a thing.
Hmm.
And you can do it now because we have the tech to do these things. And so I don't mean you get the exact custom education and put it in front of you on a plate. It's more so a resident comes to clinic and you've got two choices. One of the choices is to say, come with me, I'll teach you stuff. And that's an approach. And then the other approach is to sit down and figure out where they grew up, what makes them tick, possibly where they are on that day. It takes like 3 minutes. And let's be honest, it's kind of fun to get to know somebody, right? Figure out where they are. And then once they give you some more information about themselves and they feel heard in an education setting, it's important. Then you can say, hey, we're together for 2 months or a week or a day or whatever it is. What do you want to get out of this? Right. So that's the custom thing is to say, okay, you've told me what these goals are. And I will speak of my physician group with so much joy and happiness because we all think this way that if somebody has a learning goal, we're all going to share it with each other and make sure we all know it. And so that's what I mean by custom. The custom side of education is we don't have to drag you through our curriculum. Well, we do it to some extent. But the other part is what are you coming in here and what do you want to get out of this? And it feels more meaningful when we do it that way.
So do you also lecture or the teaching is mostly done in the clinic?
Yeah. Yeah, so in the residents, we have a fellowship that I did here too. So we've always got two fellows and their family when they come in. We treat them like family, and they're nice. They love our fellows. Also, medical students looking to do PM&R, so mentorship type things. And so buy them a cup of coffee and listen to them. They'll tell you everything you want to know, and you can help them. And every once in a while, an undergrad too. Sometimes I get given an hour of time where somebody's typically what would be a lecture, and my greatest goal, the greatest success in that would be to hear my voice the least during that time. So they give you, whether you're on Zoom, which is not ideal, or whether you're in person, to use a different modality to teach the PowerPoints and ideally get a captive audience that learns. I do some work regionally, nationally, and internationally too, where the same thing, they give you a microphone for an hour or whatever they do. And the first thing, like my first slide, whenever I have PowerPoint, it always says the same thing. Hey, the most important voice in this room is yours and not mine. And so I want you to interrupt me with questions. I want you to make sure I don't use all my PowerPoint slides because then we're talking about what you're actually here to talk about, as opposed to what I'm here to talk about. Because that's not guide it with the audience. And so, yeah, my soapbox topic on education is that lecture is dead, and that an interactive audience is a learning audience.
Awesome. I love what you were saying about really getting to know your residents, like goals and interests. And my work is really different than your work, but one of my work projects is an after school program and summer camp, a creative arts after school and summer camp program. And so I have a lot of college or just out of college age staff members. And so in some ways, it's sort of the same type of dynamic where I could just show up and be like, here's what to do, here's whatever. But one of the things that I really try to get across to them is like, what are your goals? What are you using this job for? Are you using it just for the letter of recommendation? Okay, fair enough. Like you want to clock in, clock out, but like Are you using this to explore whether you want to become a classroom teacher, whether you want to go into informal education, into business? Like some of our staff members really want to get into like the curriculum development. We have one who she's actually amazing and she's really new to our staff, but she's really interested in science and education. And so I was like, hey, do you want to get involved in our STEAM curriculum development? And so she's helping to put the STEAM plans together every week and making little lessons and discussion points for the staff. And so here now she not only is getting involved in that, but getting to put that on her resume someday that she developed STEAM programming for an informal education program. And like, how cool is that?
Right.
So, and it's also helpful to me because she's doing it and all I have to do is review it. And so I really love that approach that you were mentioning. And I hadn't thought about the way that makes it customized, but you're right. It does make it customized.
Yeah. You come by this naturally. Yeah, it's just like, it's what you do.
Okay, so what are you speaking? Back to like, what are the topics that you're speaking about?
Yeah. Actually, it was a neurology colleague of mine who I know I'm going to make sure he listens to this. He was telling me about how like you gotta get more science in these talks. He's like, our curriculum should be built on science, and there's a place for that certainly. And then he looks over at me. He's like, but you talk about the soft stuff. You're the soft stuff guy. Okay. You don't even need to prepare your talks because it's only about the soft stuff. You can prep in 30 minutes for anything you want to do, and it tends to be art of medicine things. So typical conversations, and ideally, like, how do we have somebody walk out of clinic and feel great and want to come back? Even with really, really hard conversations about spines curving certain directions, or a realization that maybe you've been trying to learn to walk for 13 years and it may not happen. Mm-hmm. Don't ever let me be the one to say it because I won't, but because I don't predict the future, right? But that realization, like coming there and still leaving clinic at some level of peace because you did it in a trusting manner, an open-hearted manner. And so, yeah, you can't measure that. You measure your success or whatever. I'm trying to do that too. So a recent topic or common topic is shared decision making. So when you're trying to make tough decisions in, say, cerebral palsy care, the physician could either walk in and tell you what to do. It's time to get Botox. Like, you could do that. Or you could say, here's my whole host of options. Here are the things we do. Here's some stuff that I know, but I don't know you as well as you know you. So how does the you apply to this? And given all that we've talked about, what do you think is right for you? And people typically know. So that's the concept of shared decision making. It's that two people bring, or two entities. So it's usually like a caregiver child unit or whatever. And you bring together two sources of different knowledge and come to a conclusion together. And that gives parents control when they have parenting control. It's hard. You get none. Yeah. Hopefully the doctor can offer you some. So that's part of it, is how do we apply shared decision-making concepts? We've taken it as far to how do we apply shared decision-making concepts to medical education. So take a step further there to say, if we do it in clinic, why can't we do it with our students? And then it's other, we've done a few times in a few different countries, the cerebral palsy sexuality conversation. Like folks that have sometimes very limited control over their bodies and a full set of hormones, but also an identity. And they may or may not talk, and they still have an identity and still experience a lot of sexual things, and if not a full complement of them. And there's a good study showing that, here, I'm using science, there's science.
It's a mix, right?
Yeah, right. There's a good study showing that if doctors don't bring up sexuality, it doesn't come up. And if you ask people, why have you talked to their doctor about sex? The answer is because they never brought it up. Mm-hmm. So that's a fun one. And then I have to advertise now because we're doing one in Belgium in May. It started as a joke, but it's actually really great. And it's the difficult parent of there's this thing in medicine about the difficult parent, and that's a really challenging dad, or that's a really challenging mom. People write books about it. I didn't write this one, but it's sitting on my desk.
He's holding up a book called Changing How We Think About Difficult Patients.
Oh, that's right. Narration. Yeah, that's the book in hand right now. I didn't write it, but it's there. And because I was talking to a friend that works in Utrecht in the Netherlands about that, and how we don't really feel that way. We don't really feel like we have difficult parents. We feel like that they come in with certain trust of the medical system and trust of the people around them and their own thing. And we care for the family. And so if the child has a problem, maybe something with their leg, and then the parent has a problem, which is their interaction with the medical environment, and they possibly carry equal weight or similar weight, or the parent might be getting in the way of the child's progress. And so we look at it as a great challenge to say, how do we earn the trust of this parent to allow their child to further advance in their own lives and treat them with the compassion because they came in with their life experiences and honor them for who they are. It's not manipulative as much as it is maybe just an open ear. Mm-hmm. But the best part of this story is this. They like this for good reason. They, in the cerebral palsy world, they like to have people on that speak with you that have lived experience. So if you're giving a talk about like something very medical, you'd be like, oh, you can bring somebody with cerebral palsy to come have this conversation with you. And when you pitch this, you have to say, okay, we got to find somebody with lived experience. And my friend Matthias actually found one. So we have a self-proclaimed angry mom that's going to join us in Bruges. In Bruges, take the train over to Bruges and join us. We talked a little bit, but I haven't met her in person. But yeah. Wow. So moral, the big picture here is that it's softer stuff in medicine, I think, in a good way.
Well, and I would imagine that there's probably a place for both the quote soft stuff and the science in any area of medicine, but especially when you're saying these sort of like long-term longitudinal patients that, the soft stuff matters so much because there is so much of that humanity that is involved. And it's not just like, oh, we just needed to get these tonsils out. There's much more conversation that has to happen. And you're really right that whether it's education or medicine or any time that you're working with kids, which all the listeners of this podcast, pretty much all of them are listening because they work with or serve youth, is like we are also serving the families and the parents and the siblings. They're all part of the picture in any of our specialties that we're working with. I just interviewed a reading specialist. And so her focus is teaching parents how to teach their kids to read. And it's like, that is, the parents are front and center in her business, but then, in any of our programs, even if all you see is the kids, you really also are seeing the parents too, because they're always part of the picture. So that's a very respectful approach that you have, that their experiences are, dictate how they show up. And it's not always in the easiest way, but it is important to work with them regardless. So.
Yeah, I heard you key in on a big word, that word humanity, because I think it's a big word in working with kids. And I get to turn this one around you, hopefully, and say like, where with the work you do, where do you find that humanity has its biggest role, or where do you feel the most humanity step in?
So I would say it depends if we are in a setting where there are only kids, because I think humanity shows up between children and in that like teacher-child relationship in different ways than when parents are in the room. So I'll say like when it is just a room full of children and the teachers there, camp counselors, whatever it is, I find the humanity shows up in their grace that they do give each other. Kids are so, and all our listeners know this too, but like kids are so incredible about just accepting other children exactly as they are. They don't need the whole backstory. They don't need so much couched language. They just accept the other kids that are there. And I think that even today, there's so much talk about how many problems we have in today's society and all that. But I think one area that we are just doing so much better, and I'm going to say we as in they, the children, are doing so much better than ever before, is in this sort of just acceptance of the wide variety of ways that kids show up, whether that's ability, whether that's gender, whether that's race, religion, whatever it is. It's just like, just fill me in on what you are and who you are and how you move the world. And I'm just going to take you at face value. And that's that. And I think for me, that's how, where I see humanity show up within, between children the most.
I like that. Yeah.
And I think that when we're talking about the family as a whole, it's a harder exercise from my vantage point to appreciate the humanity. But when we're taking other people's children into our care, into our programs, it's like these are their babies. And so remembering that no matter how old they are and, how good we are at our jobs or how confident I am that this program or that camp or whatever it is going to be successful with that child, there's that moment of like, there may be a kid who is hesitant to come or has some sort of extra that we need to understand, whether it's a food allergy or a physical difference or a cognitive difference or whatever it is. And so there's that exchange of like, you're trusting me with your child. This might be the first time you've ever handed your kid off to someone else. And, especially, I'm going down a rabbit hole here, but like, especially post COVID, we kind of got to see in such a broader way that we were often as the, so I direct a summer camp and an after school enrichment program. And so during COVID, the after school, quote unquote, was after virtual school. And obviously now it's after actual school, in-person school. But during summer camp, those for 2 years, we were often the first time that parents were handing their kid off either at all ever. These 5, 6, 7-year-olds, they had never gone because they spent their preschool years at home or first time in many years. And so there's that piece that of like pause point to appreciate that, this is somebody's baby and they're having to release control. And then likewise that they're, sometimes I have to broadcast like I'm a parent too, like as a parent I totally understand, blah blah blah, and when we are taking a little harder line, like no, you can't come to trauma class with your kid because it changes the whole dynamic of our camp or whatever it is, no, we need you to drop off here or whatever. And then I feel like I need to show them my humanity, and so there's that. So that I would say that I'm not sure if that answers your question exactly, but that's sort of how that shows up for me.
It does. Yeah. I'm pulling little pieces out of there. One piece I pulled is that probably one of the greatest honors that we have in what we do is to be trusted with the well-being of someone else's child, and that in different forms, right? Whether it's their well-being for a window of time, or whether it's the well-being for projecting their future or their physical health or any of those things. I think about this a lot. That it's such an honor to be led into that, to be allowed that opportunity to do that, to be a part of someone's life and to be led into someone else's. I mean, oftentimes not physically into their home, but right into their family as a role there. It is humbling to realize that we have that honor.
Well, and I think maybe one benefit of this show, hopefully, as it continues to grow, is that parents can hear that people in all different specialties that work with youth are giving this much thought and care and heart into the ways we can serve families that are letting us into their worlds, like you said. And we all remember our doctors when we were younger, and our camp counselors and our teachers and everything like that. We always remember that. And so my hope is that as parents are listening to this, that they are hearing like how much care does go in, because sometimes our interactions are so brief. I mean, you're in a hospital system. I would have to imagine that you, even with your out of medicine approach, you probably are still, you have to keep to a timetable. And so we sometimes can't get this whole message across. So parents out there, this is how much we think about it.
Yeah. It's nice to see that medicine's changed and that the culture has changed a lot. Maybe we just approach it. Things are being approached a little bit differently than they used to.
So this is a perfect segue to my next question. And that is that I'm sure that even within your own field, things have changed so much since you started practicing with the technology, like you mentioned, and other advancements. And so what are some ways that the specialty of PM&R, pediatric PM&R, has changed since you started? And then the flip side of that is, where do you see the field headed in another 10 to 15 years? I know you said you don't predict the future, but but what do you see coming up the pipeline?
So what's changed is things that I couldn't have predicted. So I look first at a condition called spinal muscular atrophy, and in its most severe form, it is people almost uniformly lose their life in the first year. So when I started, that was the case, and there's never an absolute, but that's the typical course of it. Not a lot of muscles moving, maybe some eyes moving a little bit, difficulty with breathing muscles from birth. It's a genetic condition. And then one day, how many years ago, maybe 7 years ago, somebody who shall remain nameless for funny reasons called me and said, "Hey, I cured spinal muscular atrophy." I laughed because that's how it went. She said, I cured it. I said, what do you mean? She's like, well, no, these kids with this condition that used to die within a year and never hold their heads up, that they walk now, and they're typically developing. I cured it, and it's true. It's cured now.
Wow.
Like, yeah, they don't need my kind of doctor if they get the treatment.
Wow.
So it's on the newborn screening. Spinal muscular atrophy in its classic form is curable now. Yeah, it's curable, and I don't even have a rehabilitation role in some of these kids' lives. If they get diagnosed on the newborn screen, we have it in our newborn screen, you'll know if you have it when you're born, to treatment, and there isn't necessarily rehabilitation to do.
So what caused that abrupt and miraculous change?
They science. Yeah. I don't science. No, I use science, but I don't create science. That's me. They create science. This group of people. It's at this hospital too. Nice. 3 different hospitals cured it in different ways, different-ish ways at the same time, kind of. But I think the first big article came out of right. I'm pointing again, but like right over there. And yeah, it went from we don't have a useful treatment to this is cured. And what that tells me is that's another reason to be totally humble about the future, which is why I can't answer and I won't answer your question. I'm sorry. I told you I can make stuff up. So if I tell people I can make stuff up, this will change. But there's no way I would have predicted, like, not only it's not just a treatment, it's like this, right? And there are a few others that have come out for different conditions since then that are like completely changed the course of people's lives in something that we see commonly. And so when people ask me, like, what's in the future, what can I expect in life, I can tell you I have absolutely no clue, and neither does anybody else. Wow. If y'all anybody out there looking for a really geeky book recommendation, the one's called Super Forecasters. It's a book. I just finished it. And it's about trying to find the people that can predict the future and what they do to predict the future. And they actually made a game out of it with a bunch of academics and had them try to predict the future every day and see who the best one was and figure out why. And the thing to learn is most people are just terrible at it. That's the first part. And the second part is the people that are really good-ish at it, like the best ones at it, are the ones that are humble, that are willing to change their mind frequently, that are willing to say that I know my best guess today, and if it's different tomorrow, I have to change my mind. Or maybe even do a 180 if I have to tomorrow, and then maybe flip back based on new information I have. And so, sorry that I can't predict the future further, but what I can tell you is that I think it's going to be totally different.
So change is the only constant, is what you're saying.
That's right.
Okay, well, that's fair enough. And what is the book called? I'm gonna link that in the show notes.
Super Forecasters.
Super Forecasters, and I am going to add that to my to read list because that sounds really interesting.
It's an interesting book, and I'll let you get your own opinion on it. I was like, this is cool. 3/4 of the way, and I was like, I can finish. You know those books?
Yeah. You're like, okay, I get the idea.
Yeah, exactly.
Mm-hmm. I have a very specific Goodreads rating. Are you on Goodreads at all?
Nah.
Okay, well, I have a very specific rating system. I think most people do. If most Goodreads users have their own specific rating system, but if a book is good, but I was ready for it to be done, then it's a 3-star for me. Like,
okay, yeah, so that's probably where it fits for me on that.
All right, well, it's fair enough that you can't predict the future. I will take that, but I guess what right now in your work are you most excited about that's happening right now? If we don't look ahead, what in 2024, or is that even still looking ahead too far?
I'm excited about tomorrow. I'll be honest. I hope that when people think about employment, that they find their way to something where you wake up in the morning and drop the teenager off at school after another one of those conversations, and then drive in and get really excited about going in to see kids in clinic or whatever you do, that it can be so exciting. I'm thinking about tomorrow and opportunities tomorrow to have an impact. And I know that sounds like it's something I could have easily made up to sound good on a podcast, but I really do feel that way, like every day, where it's like, this is really great. And I'm honored to do it. And so my future is my present. It's right now. I'm living it and I love it. And I don't want too much to change. It will, but I will change with it. And that'll be exciting, hopefully.
Well, I'll second that about finding the career that feels right for you. So that's really great. Okay, so outside of the medical clinic, I'm curious, what are the best ways that somebody who doesn't work in your field but may have kids in their lives with one of these diagnoses, one of these conditions, whether it's in our personal lives or our classroom or our camp, our workplace, what are some tips for working with a child who might be dealing with one of these conditions, who might need extra support due to one of these illnesses or injuries? What advice do you have for the rest of us?
Yeah, yeah. And maybe the same thing I do in clinic too. It's a great question. I think if you start with identity and avocation's a bad word, things they love to do for fun. If you start there, start with what makes you you first, and what makes you excited about being you, who are you, and what brings you joy and what makes you tick. And maybe what things do you do for fun, you're going to get all your answers in terms of what that kid needs right now from you, and what growth they need for a period of time. And so I store them. Sometimes I write them in the chart too, just to make sure they're there. So I'm sitting in clinic. But I've now taken on the habit of making sure that whenever I walk in a room, the first thing we talk about is the kid and themselves, and not, because the classic medicine thing we're taught is what brings you in today. I know what brought you in. You know what brought you in. That we got covered, but you look at the kid's age, and if it's a 3-year-old, you walk in, you sit down, you give them a look, and you give them a chance to talk. Maybe don't say anything, and give them a chance to talk. And if they say something, they might show you a toy. Who knows what they'll do? Here's my identity. Take a look, right? And if not, I mean, what's your favorite color? They're 3, right? Or whatever it is, right? Rainbow. I love rainbow. But I think that applies to humans in general. I learned this from this guy named Trevor Miller, and one of the best humans I know. He specializes in therapeutic recreation. It's a therapy specialty. It is community reintegration or community integration, and connecting people to things that they find recreational as a therapeutic modality. So not just go have fun for the sake of going having fun, but you're a person with, say, anxiety, for example. And these are the things that allow you to help cope with your anxiety. And sometimes it's fishing. But if there's some reason that keeps something that's preventing you from fishing, so it's like linking up those things to make it happen. Like you need to get on the bus, like whatever, or what are our barriers to reaching that recreational activity that brings us joy? Trevor's out in Portland, Oregon now, and he's the wisest. Not the wisest, because I've got great people out there in the world we see, but like I see the guy in the highest of lights. And the one thing that he taught me back in the day, way back during my fellowship, was to walk in the room and focus on a person's identity first. And this guy, he used to work here at this hospital, and esteemed to the point where if we have oftentimes you have a clinic where you see 8 different providers that you had taken care of you in the past, and sometimes there's some really intense medical stuff to take care of or whatever. I'd pop in the door and I've got some medical things that you address, and you open the door and they look at me and they're like, "Where's Trevor?" Like every time, where's Trevor? Because he had mastered this thing of really checking in with a person's identity first, or kind of locking with a person in their presence. The guy texts me, he's like, "What'd you have for breakfast today?" He does it all the time as a very natural thing. And it's just like, "Hey, I'm here. I care about you, and I want to know something about you as a person." And so maybe it's just like the thought I have with a person. It works for adults too. It's not just kids, right? But the connect when you've got a kid that may live the world a bit differently than what is typical, is like, yeah, think like Trevor, right? To try to emulate this thing of having their identity be the focus for that moment.
I love that so much. Well, Nathan, thank you so much for joining me on this podcast. One question that I ask at the end of each episode, and that is, if you could wave a magic wand on behalf of kids in 2024, what would you wish for them, and what messages would you tell them? And I think you covered some of this already, but I'm going to ask you again here.
Have you ever answered that question on your podcast?
No, I haven't.
I want you to do it. I want you to do it this time. Yeah.
Oh, man. Okay, I'll do it, and then you have to.
Sure.
Okay. If I could wave a magic wand for kids in 2024, it would be that kids would be celebrated for who they are as they grow at the different stages. I think we're really good at celebrating little kids and their interests and their hobbies and their what they want to do and their costumes and all of that. But then as kids grow, we kind of expect kids to fit into molds. And then especially once we get into the middle and high school years, we really want kids to fit into a mold of some sort. So I think that we're getting better at some areas of it, but I would wish that we continue to let kids be who they are and grow into the adults that match their inner worlds most closely. I heard this really cool quote that was like, if your kid is really crappy at math, but amazing at art, get them an art teacher, not a math tutor. And I loved that so much. It's like, we're going to be doing the things if we're happy adults, we're going to be doing the things that really lit us up as kids. And so that would be my wish if I could wave a magic wand.
Aisha, let me go first. I stole mine.
Oh, sure.
Well, yeah, so maybe I'll frame it a bit differently because it's a similar thought of maybe when we had our first kids or when we started being adults that interacted with kids, that we think of them metaphorically. Either they are like molding clay, which you can actually take your hands and you can mold them into something that they're going to become, or they're just a bowling ball rolling down a hill, and then you can put boundaries around them, like the boundaries that allow them to reach the bottom of the hill, which is maybe not the best place to land, but that concept of our adults in a kid's life, are we providing boundaries and support, and are we uplifting a kid on their own course, which they're on, and we have no control over that. They're on their own course. And so I hope for kids to be molded less, because the attempts at molding don't succeed, number one. And number two, they're probably pretty harmful, actually. And so what I hope for kids is to have a voice in their own progress, and a voice in their own direction, and have their voice be the loudest, while we as parents and physicians and teachers and everything else provide the necessary boundaries to make it fit with all the kids around them, and safe, and all those things. So less malleable and more boundaryable. And I made that word up.
I love it. That's great. Awesome. Well, if someone wants to reach out to you because they want you to speak, or if they're in need of a provider for one of the conditions that you help guide families through, what is the best way for people to reach out to you and get in touch?
Do you want to throw my email in the show notes?
Yeah, we definitely
Does that work?
will.
Yeah, that's great.
Yeah.
And I welcome that. And I've never gotten a personal email that I haven't wanted. Yeah, when it's like one person to another. Yeah.
Fair enough. Awesome. Well, thank you for joining me, and thank you for being in it for youth. I really enjoyed our conversation. I really did.
Thanks, Jamie. Appreciate it.
Thanks to all the listeners. We'll be back next time with another inspiring conversation. In It for Youth is a Lit Path Studios production. Music is by Inspiring Audio and Pond 5. Be sure to subscribe so you don't miss an episode. And to learn more about this show and all other shows on the network, visit www.litpathstudios.com.